Hello and welcome to another episode of the CIRS Group podcast. I am Barbara,
And I'm Jacie.
and today we have a very special guest, Dr. Scott McMahon. Welcome. So glad to have you here.
So glad to be here.
It's so nice. It's exciting for anyone who doesn't know Dr. McMahon. I'm sure all of our audience does. He is the very first doctor ever to become Shoemaker certified. That's quite the honor, I have to say.
Wow.
I
First in the
mean,
world?
aren't you?
Yeah. That's awesome.
Yeah, very exciting. But before we get into it, always have a medical disclaimer, though Dr. McMahon is a doctor. He is not necessarily your doctor, and this is not medical advice. And we are also not we're not medical professionals. And so, for any changes or things that you do with your CIRS healing journey, please consult your own doctor for that. But today we are getting into the topic, and Dr. McMahon is again an expert on CIRS and everything that has to do with the Shoemaker Protocol and proper treatment and all that fun stuff. But the topic today is one that I know a lot of people have asked for, so we're very excited to dig into specifically how CIRS affects children.
So, Dr. McMahon, you were the very first doctor to become Shoemaker certified, and we would love to hear a little bit about how you got into the CIRS world.
Well, that's a really interesting question, Jacie. Initially, I didn't know anything about mold. It was probably late 2009. I had been asked to speak at a conference, a medical conference in January. And the people that had asked me were kept like bugging me, sending me emails. I'd see some of them in the hospital, like, what are you going to talk about? And I didn't really know. And I had spoken to that same meeting for the previous 4 years, and I didn't want to repeat any of the topics, but I also wanted something that was going to be relevant for that group of people. And so, most people don't know this, but I've been a pastor of a church. I've done missionary work. I've done a lot of things. I've been a man of faith for about 32 years at this point. And so I prayed, and I just said, God, what do you want me to talk about? And I was expecting a one-word answer like asthma, or my music voice, asthma. I can't even get my voice deep enough. That's in honor of James Earl Jones, who would have done that much better than myself. Anyway, I was expecting something like that, but what I heard in my head was totally unbelievable and obviously not from me, because I had no way of thinking about something like this. But what I heard was pediatric mold exposure with like a colon, the next great epidemic, question mark.
Wow.
And what? And, for a few seconds, I tossed that one back and forth. And finally, because I try to live by faith, I just typed up an email and sent it to the administrators and said, this is the name of my talk, pediatric mold exposure, colon, the next great epidemic, question mark, and sent it off. And that was around Thanksgiving of 2009. And I remember kind of like looking up to heaven and saying, I don't know anything about this. I have 10 weeks to learn about this and have, 1 hour talk and a PowerPoint and everything. And about 3 weeks later, and the truth is, I didn't even know where to start in looking in the literature. So about 3 weeks later, somebody came into my office, and they had twins, and I did their checkup. And when the checkup was over, this person asked me if I would do a favor for a friend of his. And I asked, who's your friend? And it was a local businessman. And I said, isn't he suing the school district over his daughter getting sick at one of the high schools? And he said, yes. And so the light bulb went on. It's like, here's my way to get into this. I'm going to get some references from him, and I'll read those articles, and those articles will have references, and I'll get those articles, and I'll read, and I'll learn what the scientific knowledge about this is, and I'll go from there, and I'll create a talk. So that's the way I looked at it. I had no idea that this was going to be a life-changing journey. And then, so I met with him, and now it's 5 weeks later, and I asked him what he really was looking for, and he said, well, it's not just my daughter that's sick at the school. There's a whole bunch of other people. And I said, well, I'd like to meet some of these people. And he connected me with 13, and I thought of a couple other people that I knew of who had kind of, vague illness that I had never figured out what was wrong with them. And so I saw these 15 people over about a week and a half period, and we got all their lab tests and everything. And after the third patient, I was really shocked at, just how similar their experience had been. And for instance, they would describe that they would get progressively worse all week long while they were at school. Then over the weekend, they would start to feel better. And then Monday morning, they come back, and by their third period, they were feeling just terrible again, nauseated, head hurting, fatigue, just really not doing well. And so, it sounded like it was an environmental illness. And after meeting with 15 of them, I clearly could see the pattern of the illness. It really only took about 3 by the time I saw that. And I still wondered, well, how do I know this isn't something else? And then the lab tests came back. And the lab tests, if you do a bunch of lab tests on normal people, you should have about 5% abnormal, generally speaking. You'll have about 2.5% will be abnormally low, about 2.5% will be abnormally high, and the rest, that other 95%, will all be in the normal range. But what I found with these 15 people is that 58% of their lab tests were abnormal.
Wow.
And I thought, wow, there's something about this. And in the meantime, the local businessman, he had taken his daughter to a number of doctors around the country, including Dr. Shoemaker. He mentioned the name, and I went home and I Googled Dr. Shoemaker, and I found his old website before the Surviving Mold website. And I basically read everything on there. This actually kind of makes sense, and explains a lot of things that we don't really understand in medicine. And I thought, that's interesting. So then I called his office and left a message saying, I'm going to be seeing these people, and can you give me some idea of how to even start taking a biotoxin illness history? And so he called me later that day, and we spoke for about a half an hour. And I just thought, wow, this is interesting. Well, moving forward, I gave the talk. It was an amazing talk. It was one of the best talks I've ever given. The crowd was just hushed when I was finished, because I'm basically talking about an epidemic that happens from something that happens inside your house, or inside, in this case, a school, or inside your work building. And it's something that the people hadn't even thought about before, nor had I. And then after that, I went and actually visited Dr. Shoemaker in his office. I wanted to make sure that he was on the level, because I'd never heard about this before. And so I watched how he gathered his data, how he analyzed his data, I saw patients with him. I just got the full experience, and had some times to sit down and talk with him. And after that, I just realized that he was brilliant. He had discovered something that nobody had ever seen before, and that it was so transformative. It touched so many different areas of medicine that I could understand. Even as a pediatrician, I understood that this impacted multiple different areas of adult medicine, and I just was flabbergasted. So I came back and I offered treatment to those 15 families, and 5 of them took it very seriously. They did the treatment and they got much better. And the other 10 either didn't do the treatment or didn't take it very seriously and stopped within a couple, 3 days, and none of them got better. And over the years, many of them have come back to me and have gotten serious about treatment, and they got better. So I was really able to see this whole thing. It started out as a divine inspiration to show me a door that I wouldn't have otherwise seen. And then after that, my rational mind took over, and I found the data, and I found I talked with Dr. Shoemaker. I found the medical literature that supported what he said. I watched his methods. I tested it myself. We did our own lab test, and it just came out unbelievably well. And after that, I've treated many, well over 1,000 patients. I've evaluated over 2,000 at this point. And just have come to the conclusion that this works. And I'm always waiting to find people that, don't get better. And that's so unusual. I'm still amazed. I'm still amazed. And I'm amazed that, Western medicine hasn't adopted this. I have my thoughts on why, but they will. They will. I mean, we're reaching a tipping point, and once we reach that, there will be no going back. And then people are going to say, "Oh, wow, this is real," and they're going to start studying it and throwing millions of dollars of research at it, maybe billions of dollars, because they're currently wasting billions of dollars looking at other illnesses that we don't even have a pathophysiology for. And most of that is probably CIRS at the beginning, or CIRS in a progressed manner.
Wow, that's amazing. I love how you just followed that path that you were given, basically, and look at all of the amazing work that you've done since then in this sphere of helping people in that way. That's awesome. You did mention, obviously, your focus was children at the beginning, and you noticed how the implications for adults as well. But I'm curious what the difference that you've seen in children versus adults when treating CIRS, and how it manifests, and what that experience is even like. Are there differences between kids and adults?
Yeah, adults tend to be a lot grumpier, and they're a lot taller, and they usually weigh more. And sometimes they can drive. So,
right.
There's a saying in pediatrics that children are not small adults. Of course, to some degree they are, but we actually look at children in a different manner that I believe than, say, an internal medicine doctor will look at an adult to some degree. We still are looking at the same systems and whatnot. We just understand that in pediatrics, those systems are evolving as the child is growing and developing and maturing. Those systems are evolving and changing. For instance, the blood pressure of a baby is not what the blood pressure of an adult would be. But by the time you're about 10 years old, the child has pretty much an adult blood pressure. So pediatrics is a lot about watching those changes. And I had the opportunity of evaluating something like 700 kids from my own pediatric practice, and did a couple of research papers on what we saw, and have given a number of talks. One of the biggest differences between children is that they haven't been exposed for nearly as long as adults have, generally speaking. And one of the things that we see is children get better much faster. Children tend to have fewer symptoms. Children have fewer symptom clusters. Children have less ability to express, whether they're having a particular symptom or not. For instance, if I were to ask a 3-year-old if he was having vertigo, it would be, I wouldn't get much of an answer, or metallic taste. No matter how good I am at breaking the question down, it's going to be really hard for them to communicate some of the sensations that they're having, some of the symptoms that they're having.
Right.
So with children, we have a lower criteria necessary to make the diagnosis. And I've seen a lot of children that are, say, less than 5 years old, less than 6 years old. It's very difficult for you to get a really good history on them. And history is like the most important part of what we do as doctors. So what I realized after time was that the most common symptoms that we would find in children were chronic fatigue, chronic headaches, and chronic stomach issues. And I'll tell you that within pediatrics, children that have chronic stomach issues, there's a particular workup that you can do. We only find the answer about 10% of the time as to why they have these chronic stomach issues and pains. Maybe they don't want to eat dinner. Maybe they don't want to play. Maybe they don't want to go to school because their stomach bothers them. And what I was taught, I went to a top 10 pediatric residency, and what I was taught then is about the same as what we're taught now. And that is that for that 90%, it's all in their head. All in their head. Now we don't say that. We say it's functional. We say that there's no physiology behind it. But when you say there's no physiology behind it, that's based on the lab tests that we knew how to do and the imaging tests that we knew how to do to kind of try and figure out what was going on. And if all those come out normal, then we say there's no physiology. But the lab tests that Dr. Shoemaker came up with, like the TGF beta 1, the MMP9, the C4A, are abnormal in children too. And so are the low VIP and low MSH. They have the same HLA haplotypes. So there really are abnormal tests that you can do that show that there's a physiology or a pathophysiology that's going on. It's just that most of Western medicine hasn't seen that. They're not familiar with these tests. But we've evaluated thousands of people and find that they're always going to have at least 4 of these tests abnormal. Now, I honestly don't know of any other illness that requires 4 abnormalities of lab tests to make a diagnosis. If you have strep throat, they swab your throat. And, if it's positive, it's strep throat. That's one thing. Or maybe you might see redness and pus. So now you've got 2 objective markers. There's just, the amount of data that we have showing that this is an illness is incomprehensible. It's just, and the fact that some people still want to believe it doesn't exist. I'm kind of going off the question, aren't I? Sorry, let's get back to children.
No, it's fine. But to your point, that it just breaks my heart to think of how many children out there have been told by their doctor, or maybe the doctor told their parent, it's all in their head. And just because they didn't have they don't know the proper tests, or they've rejected the proper tests, whatever the case is, to actually figure that out.
That's right. So what they taught me in residency was that there's a primary gain and there's a secondary gain. So primary gain would be like a child who knows that he has a history test today and he didn't study for it last night. So he'll kind of make up a reason to not go to school. And maybe it's my stomach aches or my stomach hurts. And so that they don't have to go to school, so that they don't have to take the test. A secondary gain might be more subtle, something like maybe the child is getting bullied at school and doesn't really want to be at school, but isn't, and as a result of the stress of being bullied, ends up having a stomach ache or some other symptom. And so they use that to not go to school. Primary and secondary gain. That's what we were taught 90% will have. But my data shows that if you take that 90% that don't have some other obvious reason for belly pain, like constipation or urinary tract infections or something wrong with their liver or their pancreas or something, you don't have that other 90%, about 90% of them will have abnormal labs that will show that they have chronic inflammatory response syndrome.
Wow.
And when you treat them with lower doses of cholestyramine for shorter periods of time, they can have 100% improvement depending on age and how long they've been exposed. But they can have 100% improvement within 2 weeks. And
Wow.
their stomach aches go away, their headaches, which are also thought to be a stress-related problem, their headaches go away, and their fatigue can go away, and they can be 100% back to normal. There are 3 other symptoms that I found are very common in young kids, particularly around 6 years of age. One of them is inattention. So whenever I have a child, I haven't been doing active pediatric practice for the last 4 years in a clinical setting. I still work at the hospital, but in my office, when I was seeing patients in that clinical setting, if they were being evaluated for attention deficit, whether with hyperactivity or without, I would also evaluate them for CIRS. And sometimes we found that just treating them with cholestyramine for a couple weeks was enough to make their inattention go away.
Wow.
So it needs to be part of the differential diagnosis of kids who have inattention, along with, it's just not always ADHD. There are other things that can be causing that in children. So another symptom that I discovered was that if a child wasn't completely toilet trained by 6 years of age, that oftentimes it was the polyuria that we see from CIRS. Wow. So
That
again,
frequent urination urge, all of that, that I know all of the adults are very familiar with. Yeah, it affects kids even more because they don't have that ability, I guess. They haven't, it's so, the urge is so bad that they can't overcome that with, going to actually physically taking themselves to the bathroom at that point.
yes, or it happens at night while they're asleep.
Sure.
So,
Right.
so within pediatrics, we consider that everybody by the age of 6 years of age should have become fully toilet trained. So toilet trained during the day, toilet trained during the night. And we know that about 10% of kids aren't, and most of those are uh, boys, and most of those are really deep sleepers, so they don't wake up in the middle of the night. And what's supposed to happen is as you're going through toilet training, you actually train your brain at nighttime to secrete extra levels of antidiuretic hormone, ADH. And that antidiuretic hormone tells your kidneys to not make so much urine overnight. You still make some, but not nearly as much. And so when you wake up in the morning, your bladder is full and you go and you relieve yourself and you start the day and your amount of antidiuretic hormone being secreted goes down. So that's actually what happens when you're body training is you're training your brain to release extra antidiuretic hormone. But we know that somewhere around 85 to 86% of patients with CIRS have an abnormality in their antidiuretic hormone when you correlate that with the serum osmolality. And without getting too complicated here, your brain is constantly measuring your serum osmolality or how thick your blood is, how concentrated it is. Or another way of looking at it is how much salt do you have in your blood. And it's looking at that. And as that's climbing, as that osmolality is going up, then you are getting more and more dehydrated. And the body's response to that from the brain is to secrete antidiuretic hormone, which tells your kidneys to stop making urine and save that extra water, save the free water. At the same point, those same things trigger your thirst, so you want to drink more. Now, if you're continuing to drink more, but you don't have an adequate amount of antidiuretic hormone, guess what? You're going to pee. All that water that you just drank or Kool-Aid or Coke or whatever you're drinking is going to go into your, it's going to go through your gut and get absorbed. The water of that is going to get absorbed. And because you don't have adequate antidiuretic hormone, you're going to pee and pee and pee and pee. And if it's in the middle of the night, there's a really good chance you're going to wet yourself, especially if you're a deep sleeper. So we've been trained to think that this is something that's going wrong with the brain, and it is. People just haven't been doing the right tests to see what the problem is. It's almost like a form of diabetes insipidus. So that's another symptom that I see in children is if they're not toilet trained by 6 years of age, we need to evaluate that maybe this is a CIRS symptom. And then the final thing that I look at in small children is growing pains. Now, there was a time when we thought that growing pains were associated with growth, like growth spurts in children. But more exacting science has found that there's actually no relationship between growth spurts and growing pains. They're just called growing pains because they thought they were related to growth spurts. But there's no association. And what that means is pediatricians really have no idea what causes these myalgias, these muscle aches and pains in children. It can be 2 years of age. They can be complaining of that. And so what I decided was to kind of look at that. And what I found is when kids have been having growing pains for more than a couple of months, about 85 to 90% of the time, they would have the lab tests that showed that they had CIRS. And then when I treated them, again with cholestyramine, usually for a couple of weeks, their growing pains, which may have been going on for months or even years, went away. It's really phenomenal. Wow. So 6 symptoms that I see, very frequently in children. And I say this really for parents who are watching. If you're thinking your child might have CIRS, you're going to see almost always at least one of these 6. And if you see 2 or 3 of them, they probably do have CIRS. If you only see one, they should at least be evaluated for CIRS. And again, that's not potty trained by 6 months of age, 6 years of age. I'm sorry, inattention, usually in kindergarten, first grade, around 5 to 6 years of age, frequent muscle aches that are called growing pains, chronic fatigue, chronic headaches, or chronic stomach issues. If you see any one of those in a child that's, say, 6, 7, or younger, you need to be evaluated for CIRS. And children at that age may only have one system abnormality. We talk about CIRS as a multi-system illness, which means that different areas of your body are affected. In Western medicine, we look at the eyes, for instance, and we call that the ophthalmic system, and your ability to see and more. And then we look at the hearing, and we have an audio system there. We look at the heart pumping blood through the blood vessels. We call that the cardiovascular system. The lungs breathing in air and bringing the oxygen in. We call that the respiratory system. But it also includes the ears that get infected with ear infections, the nose, and all that. So we have these different systems in the body, and they're not completely separate from each other, but we look at them separately. And if you look at the different specialists that we have in medicine, you'll see that they follow different systems like that. And in the immune system, we have immunologists, we have allergists, we have rheumatologists, but we don't have any specialists for what happens when there's a problem with the innate immune system. So yet another reason why Western medicine hasn't discovered this yet, or at least many doctors within Western medicine haven't seen it. I'm getting off point again. There we go.
It's good info, though. We're not stopping you.
So CIRS is a multi-system illness. It's not just one issue. So if I were to talk to an adult and they say, I have these really bad headaches, but they don't have any other issues. They don't have chronic fatigue. They don't have stomach issues. They don't have sleep problems. They don't have hormonal issues. They don't have any of the other things that we look at in CIRS. Then I'm not thinking CIRS. It's a multi-system illness. It affects multiple different areas. But with children who have only been exposed for a shorter period of time, it can be a one-system illness. And you say, well, why would that be? It's like, well, if you're born with no systems involved, and by the time you're 11, you've got 6 or 7 systems involved, at some point you had to cross over 1, and somewhere else 2 and 3. So those systems started getting added. It's possible that you can start out with 3 and 4 system problems, but some people will start out with just 1. And those 6 symptoms that I talked about, if I saw any of those 6 symptoms in a pediatric patient, I would be at least thinking about in my differential diagnosis as to why that child is suffering that symptom. I'm thinking there's the possibility of CIRS. And my experience is if you have 2 or 3 or more, then it's almost always CIRS that's causing that in these young children. So just a couple thoughts about how children differ from adults.
That's great. No, it covers so much.
Yeah, it's incredible to me that I'm so glad you put it out there that if your child is suffering from one main thing, don't wait till it's 2 or 3 or 4 or more. Do the evaluation. It's no harm, and it'll give them more information for moving forward. If they have CIRS, they can treat it. If they don't have CIRS, it's one more thing off the table for whatever they do end up pursuing. And you mentioned that kids typically, they go on the cholestyramine, but it's a smaller dose and it's for a shorter period of time. So can you talk a little bit about how the Shoemaker Protocol differs between children and adults?
So for adults, we usually treat with 4 grams of cholestyramine 4 times a day if they're 120 pounds or heavier. If they're between 90 pounds and 120 pounds, we do 4 grams of medicine of the cholestyramine 3 times a day. But if you're below 90 pounds, so now we're really talking about children, the dose is 60 milligrams per kilogram 3 times a day for however long that you need it. And so that's actually a considerably smaller dose in children than those who, once they've reached 90 pounds. There's also a difference in the duration. So if you're using cholestyramine in a small child, typically, if they're 5 or less, I tell the parents 2 weeks, and I've seen just amazing turnarounds in 2 weeks. 2 weeks.
That's
Can you
incredible.
imagine that? I mean, I'm saying that to the patients that have been suffering for 5, 10, 20 years with this. Can you imagine if somebody had known about this when you were a child, they
Mhm.
could have dealt with it in 2 weeks and then giving you the information about water damaged buildings, or you never, if you were able to stay out of water damage, you'll just never get sick ever again with this illness. I mean, that's just mind blowing to me.
Amazing.
But 2 weeks. And as you get closer to 9, 10, 11 pounds, it's probably more like a month, maybe 2 months of that smaller dose based on your weight. When we treat adults, the book says 1 month. It's really 1 to 2 months. Oftentimes at 1 month, I'm seeing people having, some small improvements, but not the really big ones that you want in cognition, in exercise, in exercise tolerance, in just general energy. I don't usually see that until they've been on cholestyramine closer to 2 months. But by that time, they're having improvement in most of their symptoms and feeling a lot better. So what I tell adults, who ask me how long they should take cholestyramine, I say, it's going to be 1 to 2 months, but maybe 2 to 3 months, and occasionally 3 to 4 months. I'll be honest, I've seen people who have been on it for very long periods of time. They say they can't come off of it without their symptoms getting much worse. That really concerns me. I don't ever want to see one of my patients who's on cholestyramine for very long periods, more than 6 months or so, because I'm concerned about the leaching of minerals out of their bones and out of their body, the ADEK, fat soluble vitamins, and the like. And so that concerns me if I saw somebody who had been on it for a very long time. But yeah, for children, for little children, 2 weeks compared to say 4 months for an adult.
And I've heard too that with kids, they don't necessarily need to do the VIP step, the last step of the Shoemaker Protocol. A lot of kids get full recovery from just cholestyramine alone. Is that true?
That's correct. And as a pediatrician, I don't recommend VIP for most of my patients. I think that VIP in children is still pretty much experimental. I've used it in about 30 kids at this point, had amazing improvements in almost all of them. I've not had terrible side effects where I had to stop the medicine in any of them, but I haven't seen much peer reviewed, if any, published data about VIP in children, and that's why I'm hesitant. I usually recommend to internal medicine people and even family practitioners that you probably shouldn't consider using VIP in children just because their training is different. When I do use VIP in children, I don't start at the regular dose, like one spray 4 times a day of the 50 micrograms per spray of VIP. I usually start at a concentration that's 1/100th of that because I don't know what the right dose is for children. And so I start small to make sure that I'm not doing any harm. And we have a protocol where we gradually increase it. And then the maximum dose for most children is going to be one spray 4 times a day, the dose that adults would start at. If it's a larger kid who's 16 or 17 years old and weighing 150 pounds, there's the potential to go up. But anytime I'm using VIP in somebody who's under the age of 18, I have an informed consent. I require both parents to sign it. If the child is 10 years or older, I require that child to sign an informed assent. They're not old enough to give consent, so, but it's an assent that this. I'm telling them this is experimental. It may help you a lot, but we don't know, and so we want your agreement with us doing it. But I have found in those 30 kids that I've used it in, I have seen absolute miracles. I have seen unbelievable changes. It first started with a 14-year-old, and she had not been to school for almost 4 years because of her CIRS and probably had a considerable amount of Lyme and co-infection problems also. And she was only eating 3 foods. She was eating a vegetable, chicken, and rice and could only drink water. And anything else, everything else just made her sick, made her turn gray. It was just awful. So we started her on VIP at the 1 to 100, worked it up, and she, within about 2 months, was going to school. Within a couple of weeks, she was eating better.
Wow.
And it was just like, it blew my mind when I said I had no idea we're going to see that kind of improvement. Then I had another child who had been, like, the day after his first birthday. He wasn't my patient. He was from another state. And the day after his first birthday, he started having chronic diarrhea with blood. And it was massive and it was awful. And he got hospitalized by his pediatrician. And then he got sent to a higher level hospital, which is actually one that I deal with. And when I was actively taking care of kids, sometimes I sent people to that. So I know the people that were there, and they did everything they could. And then they sent him to an even higher level, like the equivalent of a Mayo Clinic for children. And they didn't know what was going on. They did biopsies, they did, endoscopies, they did colonoscopies, they did everything they could. They couldn't figure it out. And the mom started doing some research, and she found out about mold, and she talked to another person, and that person suggested that next time they do a colonoscopy, that they go ahead and get a biopsy and look for mycotoxins. And sure enough, they found like massive ochratoxin A in this kid's gut.
Mm.
And of course, by this time it's his third hospitalization. They still haven't figured out why he's having bloody diarrhea. They haven't figured out, why he can't gain weight, why he can't eat. I mean, this is really just a tragic case.
That's
until
horrifying.
they figured it out. And then they started giving him charcoal. They didn't give him cholestyramine. They gave him charcoal. And he started getting better, and the bloody diarrhea went away, and he started being able to eat. And, he started getting better. And I started seeing him about 2 years after the initial thing. And he still was having cognitive issues. He was having behavior issues, and he still wasn't gaining weight that well. And so I reviewed the charts. I looked through everything, saw what this other doctor had done, and said, charcoal is okay. I personally call it a wimpy binder. It's okay. People get better over a long period of time. Let's try him on some cholestyramine. And within a month, I would say, within a month, he was doing great. He was feeling super. He was going to school. He was preschool, I'm sorry. And he was doing well, but he was still having behavioral issues. He was having meltdowns every day that were lasting 3 and 4 hours non-stop.
Yeah.
Wow.
And at the time, he was one of like 7 children, and mom homeschooled. So you can imagine how disruptive that would be to have a child screaming nonstop for 4 hours. And sometimes he'd do it twice a day. So we finished the rest of the Shoemaker Protocol that we needed to. And I said to her, we've tried this VIP once before, with this girl with a stomach issue. I don't know if it'll help your son or not. But if you're interested, we can try it. We got the informed consents. Within 2 weeks, his behavioral issues were gone. Now, mom had to give the dose 4 times a day. And what she told me was, if it was even 40 minutes late, he would start having problems again. So we increased the dose a little bit to kind of cover a little bit longer. And within 2 months, he never had another behavioral issue. Within 2 months of VIP. And then we weaned him off. And it's now 8 years later, and he's the top kid in his class, and he's the teacher's pet. Everybody loves him. He's sweet and kind and just a very lovable child. He now goes to school. Is that crazy?
I was going to ask if he was still homeschooled, and if he's the teacher's pet, that must be awkward for the other kids, but it sounds like he's going to public school.
Yeah. I think once he hit about 3rd or 4th grade, the mom had a couple more children. So he all the older kids were in public school by that time.
That makes sense.
Mama is prolific.
So since obviously genetics are involved, and probably a lot of our listeners are adults with CIRS, and probably a lot of them have kids. What is your recommendation for, I guess, how and when to have that conversation with that kid, kind of to prepare them or to educate them or inform them of what their life is going to have to be like, the adjustments that people with CIRS need to make to avoid, water damaged buildings, like you mentioned before. Yeah, I would love to hear what your thoughts are on that.
Yeah, that's a good question, and I think part of it also has to do with if two adults, the mom and the dad, actually know their genetics, then you can predict what the likelihood is for each child. So, for instance, if a mom has a dreaded and a mold, uh, every child that she has is going to get either the dreaded or the mold, regardless of what dad has. It's just the way the genetics work out. Same for dad. So if you have, a mom who has a dreaded and a mold and a dad who has two dreadeds, guess what? Dad's going to pass a dreaded on, mom's going to pass either her dread or mold, and you know that child is going to be a double. It's going to have, either two dreadeds or a dreaded and a mold. That's the reality of it. Alternatively, if for some reason dad's haplotypes and he's good and mom has one mold one, then it's a 50-50 chance that each child, it'll be 50-50 for each child, that they will have that mold. So that's where we start with is, what actual genetics does the child have? They could have 0, they could have one bad haplotype, or they could have 2.
Right.
And in my experience with children, the illness isn't worse if you have 2 over if you have 1. It's not worse. It just shows up earlier in life, is my experience. Okay, I haven't published that, but that's just what I've observed from the data that I've collected. Okay. So moving forward, once you know that your child is is genetically predisposed, it's your job as a parent to do everything you can to minimize the exposure. So that's your house. When time comes that they're either going to go to daycare or to school, you need to investigate the schools that they're going to be in and try and make sure that they are not getting exposed. And that's how you keep them from getting sick. Alternatively, if you know that your child is exposed and you're wondering, when should I take him to the doctor? When should I, maybe get blood work? I would say you should wait and watch for one of those 6 symptoms that I mentioned before. I'll go through them again really quickly. Chronic fatigue, chronic headaches, chronic stomach aches, recurrent myalgias that are usually referred to as growth pains by pediatricians. They're 6 years old and they're not completely toilet trained. And any thought that they might have an ADHD or ADD kind of problem in attention at school. So if you saw any of those 6 and you knew they had a genetic predisposition, that's probably time to go see the doctor. Now, to get to your actual question, and I'm sorry, when I say the doctor, I mean one that knows about CIRS.
Yeah.
Because if you go to a pediatrician and they don't know about CIRS, they're just going to kind of roll their eyes at you or blow you off and say, oh no, he's fine. We'll investigate this. And their differential diagnosis will not include the illness that might be, maybe is most likely the cause of the symptom.
Right.
And that's just something that's going to change in medicine. It's already changing in medicine. The data is so overwhelming. It is changing in medicine, but there's a ways to go still. And then again, getting back to your question, when do you start instructing the child about their environments? I think some of that has to do with the maturity of the child, and some of that has to do with the genetic predisposition, and some of that has to do with whether they're symptomatic or not. In any case, probably around the age of 8 or 9, at some point you have to explain why Johnny can't go over to his friend Jimmy's house for the sleepover because Jimmy's house is moldy, or why you need to go to a different school because that school is giving you symptoms and you need to go to a place that's less likely to. Certainly by the time that they're 10 or 11 and they're starting to make more choices for themselves, you want to start the education process. Remember, just like in 7 or 8 years, they're going to be going to college, and their college choice and the dorms that they stay in, or if they stay in the dorms, that's all involved with this. And those are decisions that are best made, with parents and children together making those decisions. As they get to be 13, 14, 15 years old and they're looking at getting a job, they need to know that the place that they're looking at to be employed, if there is an office or something like that, needs to not be a water damaged building. You need to train them to kind of look around, look for staining. You need to sniff and determine whether you smell musty or mildewy smells. And the other part is, if they do have CIRS, some children, it's mostly adults, but some children will develop a sensitivity. So when they walk into, I always say Whole Foods, that's not fair, but if they walk into a grocery store, there we go, that is water damaged, okay, and they feel funny, they feel different, their head starts hurting, they start getting nauseated, or their nose starts running, or whatever the symptoms are that distinguish for them, because it's different for different people, they should be educated that that's real and that they need to pay attention to that. And that means to get out of that place as quickly as you possibly can.
Yeah, that's great information. And a follow-up to that, because you mentioned, most doctors don't know, pediatricians especially, and that is changing. Do you have advice for parents as to how to approach? Maybe they have a pretty cool pediatrician, they seem kind of open. How would you, like, if you were in their shoes as a pediatrician before you knew about mold, how would you like a parent to approach you about maybe getting some of these blood markers tested and all of that, and going down this rabbit hole?
It is always good to come with peer-reviewed, published literature that supports what you're saying. Or some people will bring a book like Surviving Mold, but I'm going to be honest with you, Surviving Mold is 700 pages. And if somebody had brought that to me 15 years ago, I probably wouldn't have read it.
Sure.
Or maybe I would have read the first chapter. And if it engaged me, maybe I would have read through it. But 700 pages is a lot of time. And I'm not a speed reader. And I've got 8 children and a wife. And I've got a lot of things to deal with. So I probably wouldn't have done that. If you brought, though, like 2 or 3 papers from the peer-reviewed published literature, that's something that somebody is more likely to try and digest. An example of one of those might be the 2020 systematic review that Ming Dooley and I wrote that looked at all of the peer-reviewed published literature that was relating water damaged buildings, specifically increased dampness and increased microbial growth versus adverse human health effects. And it's an overwhelming study. It is so completely in favor of what we do, showing that single and multi-system illness is the result of people who go into water damaged buildings. And this wasn't even looking at people that were predisposed. Whereas most of these studies weren't looking at a genetic predisposition. They were just showing that if you take a population that spends a lot of time, like say for instance at school, and that school is water damaged, and then you look at another population, they're not spending a lot of time in a water damaged school because their school is not water damaged, we see increased headaches, we see increased neurological issues, we see increased allergies, increased respiratory symptoms, increased asthma, increased myalgias, increased other musculoskeletal issues. Just go down the line of CIRS symptoms, and most of them are covered in that medical literature. It's an absolutely phenomenal study. It's just like 37 symptoms. And it may sound like I'm patting myself on the back, but someday people are going to look through it and they're going to say, that's a breakthrough article, just like Dr. Shoemaker's original articles on CIRS, and most of his articles they're just bringing in information that nobody has seen before, nobody's documented before, and showing, yeah, this is real. So that's one. Another would be the 2018 diagnostic paper that Dr. Shoemaker published with a number of us as co-authors. That's another really good one that looks at the data that's in the literature and puts it together and shows this is how you make the diagnosis, this is how you treat, these are other things that you need to think about in your differential diagnosis, this is the way you do a physical exam and whatnot. So those kind of studies, again, they're kind of long because they're review studies and they're comprehensive. But if you're you're taking a doctor who has an open mind and is willing to learn, those are really good ones to show that, yeah, this is an illness that you might not be aware of and that maybe you want to do a little more study on.
We'll
Additionally,
link to those studies, by the way, for anyone
okay,
listening in the show
thank you.
notes.
Yes, and Dr. McMahon, we can't thank you enough for all the work you've done in the CIRS community and the work that you've published so that people have these resources that they can bring to their doctors and bring to their workplaces to prove the existence of CIRS and prove their experience that it's not all in their head, whether you're an adult or you're a kid. We can't thank you enough for coming on and sharing your expertise with us and with our listeners.
Yeah.
Well, it's been my pleasure, Jacie, and also Barbara. Thank you guys for inviting me. I hope to have you on my podcast someday.
Yeah. Tell us about your podcast before we go.
Okay.
What people can look forward to.
My podcast is called Medicine and Miracles, and it's usually about 15 or 20 minutes long. And I usually go through some area of science, some area of medicine, and talk about it and what I know and break it down in a way that you don't have to be a scientist to understand it. And then I segue from there into a miracle that I've seen. And I've already written down about 30 different miracles that I've seen. Sometimes they're miracles of healing. Sometimes they're miracles in financial realms. Sometimes they're miracles in other things. And I just go through one of the miracles that I've seen. And then we end on a happy note, on an uplifting note. It's really pretty cool, I think. And it's coming out soon.
Yeah, that's exciting. And we'll update with links to the show notes here when that does come out. And of course we'll have your website and all the other ways to get in touch with you and see your work as well in the show notes. And I know also, Doctor, you are very involved in CIRSx, which is the annual conference that Jacie and I have now attended 2 years in a row. We're excited about next year's. Did you want to plug when and where that will be?
Absolutely. I think I met you guys at CIRSx 2 years ago in Boulder.
Yep.
Yeah. I didn't understand who you guys were back then. I did know what a podcast was, but I hadn't seen yours. Then I saw your podcast, like, wow, you guys are great.
Aw, thanks.
Yeah. So thank you. Yeah. So in June, the weekend of June 5th, we're going to be assembling for the next CIRSx conference in Tempe, Arizona. We were going to do it in July, but we heard that the average temperature is like 120 during the day. So we thought we'd have mercy on all of you guys. But it's going to be a brand new build hotel. It's not even 1.5 years old, is my understanding. I haven't been to it, but Dr. Dorninger has. I think, well, Dr. Dorninger either collected samples or Greg Weatherman collected samples, and so had acceptable HERTSME-2 scores. So I'm excited. Of course, can't guarantee it'll still be that way next June, but right now the hotel looks like it's in tip-top shape for people that suffer. The conference is always geared toward patients, toward providers, toward medical providers, toward indoor environmental professionals, and the last couple of years toward legal people who have interest in this too. So I'm very excited for this, and it's always a hoot, and it's an amazing conference, and it's just good to get together with the CIRS family.
Yes.
That all understand how vital this subject is, and who are all contributing in their way to bringing worldwide understanding. Like
Absolutely.
You guys, thank you so much.
Yeah, no, it's just the highlight of our year to go there and see everybody in person. It's really nice. And for those of you worried about the environment, because for CIRS patients, sometimes travel, especially if you're in the middle of the protocol, you won't want to. There are virtual tickets so you can attend and watch the live stream as it happens. So that's also available for people who want to attend that way. So yeah. And we will be there. Jacie and I will be there, and I know Dr. McMahon will too. So we'll all be together, and hopefully we'll see some of you out there too.
And if you just can't wait until June 5th and you want more CIRS content, we are super excited to, I think this is the first public announcement we've made about this. We're participating in the CIRS Summit. This is going to be an online virtual summit. It's going to be all of the CIRS experts we know and love, including Dr. McMahon. Thank you so much for participating. We're so excited. But it'll be coming out the first week of December. You can watch all of the talks live. They'll be available after the fact as well. And it's really patient focused. So that is the goal of the summit, is just disseminating the amazing information that's locked inside of all of these providers, remediators, coaches' brains, and providing them to you. So save the date, early December. We'll definitely have more information out soon.
I can't wait. I'm going to be speaking on HLA, and I've told myself I'm not going to use any words that have more than 3 syllables.
Good
Well,
luck.
I personally appreciate that.
Yeah.
Haplotype.
Yeah.
Ooh, I'm already at the limit.
Damn. Oh, I'm excited for that. Awesome. Well, yeah, thank you so much again, Dr. McMahon. And for those of you looking for more info and support and resources for your CIRS healing journey, join us over at the cirsgroup.com.
We'll see you there.